is Dr. Ruma. Take one. Mark?
Thanks so much for joining. I'm Dr. Mike Ruma, and I want to talk to you today about optimizing the preterm labor evaluation. I want to first tell you who I am and a little bit about myself. I grew up in Omaha, Nebraska. I was a Fighting Irish fan at the University of Notre Dame. Went to Creighton University School of Medicine, and then OB/GYN training also at Creighton. Did fellowship training at the University of North Carolina, Chapel Hill. Did a master's in health policy and administration there. And have been in private perinatal practice in New Mexico for the last 17 years. First, we're going to introduce the problem of spontaneous preterm birth. Then I'd like to review our current ability to predict spontaneous preterm birth. Talk about the importance of standardization, summarize a number of clinical studies, and then review and discuss our current recommendations from societal guidelines. Let's talk about the problem. Preterm birth is any delivery that occurs prior to 37 weeks. It's one of the most devastating problems facing obstetrics today. Roberto Romero, one of the most preeminent researchers in the United States in perinatal medicine, has said, preterm delivery has been and remains the most important challenge to modern obstetrics. And if we go to Europe, to England, Dr. Stuart Campbell, a preeminent, renowned researcher in Europe, has stated that preterm delivery, with its collateral effects on neonatal mortality, short and long-term infant morbidity, and astronomical healthcare costs, is the foremost problem in modern obstetrics. 2 individuals across the globe describing the same issue. Why is this problem such a particular topic that we want to pay attention to? Preterm birth is the leading cause of infant morbidity and mortality worldwide. As a patient delivers a preterm infant from 22, 23, 24 weeks, the outcomes only improve the farther along that patient makes it in her pregnancy. Preterm infants face a high rate of death, a number of short-term immediate complications, respiratory distress, intraventricular hemorrhage, sepsis, necrotizing enterocolitis. And those preterm infants go on to face a number of long-term issues as well: neurodevelopmental disorders, lung disease, blindness, and deafness. Preterm birth can be divided into spontaneous and medically indicated. 70% of preterm births are spontaneous. 45% of those are preterm labor, 25% preterm premature rupture of membranes. The other 30% are medically indicated. The patient develops preeclampsia. She has uncontrolled blood pressures. She has a severe headache. She requires medically indicated delivery. We're going to talk today about these spontaneous preterm births. Preterm birth is a major issue in the United States. In 2023, we had just over 3.5 million births in the United States, of which 373,000, or 10.4%, were born preterm. This map represents that this problem is not unique to any particular state. It's a problem that affects the entire United States. Despite sophisticated research and a lot of therapeutic advancements, preterm birth still remains in the United States a major issue, and its rate has remained the same and even seems to be rising. The March of Dimes has presented information and data over the last decade. Our preterm birth rates have gone from around 9% upwards of 10.5%, and you can see in this graph that preterm birth rates are rising in the United States. Preterm birth is also inequitable. It affects women of color in a greater percentage, and Black women have a 1.4 times higher rate of preterm birth as compared to non-Black pregnant patients. While the cure to prevent preterm birth is elusive to researchers, scientists, and doctors, clinicians, physicians, nursing staff, trainees, all people involved in medicine, there still is a possibility to make beneficial impact on this particular problem today. Preterm labor manifests itself in a variety of ways. And we need to differentiate preterm labor from preterm contractions. True preterm labor, or painful preterm contractions with cervical change and a high risk of preterm delivery, is different than preterm contractions that maybe are not painful without cervical change, that don't require prompt intervention. The reality of evaluating patients with preterm labor is the greatest majority of them are going to go on and deliver at term. Of patients hospitalized for preterm labor, half of those patients ultimately deliver at term. And for patients that present obstetric triage, labor and delivery units with symptoms of preterm labor, only around 10% of those patients actually deliver within a week. How can we make an impact today? There are a variety of options that we need to take into account and assess when you are looking at a patient with symptoms of preterm labor. We need to do a clinical assessment, take a medical history, place the patient on a tachometer, and then evaluate her cervical dilation and effacement. We can also do an ultrasound and assess the patient's transvaginal cervical length. And we also can complete a laboratory test, fetal fibronectin. Each of these components have different predictive abilities, which are important in our decision-making about what we want to do to and for that patient. Cervical examination by itself is not an excellent predictor of preterm birth. As you can see, a patient that's only minimally dilated 1 centimeter, 84% of those patients deliver over a week later. Even if she's 2 centimeters dilated, 70% of those patients deliver a week later. What can we do now? We can also do a cervical length. If you're going to do a cervical length, ideally we have some training, education, and understanding about how to approach a patient with transvaginal ultrasound. Cervical length ideally should be done vaginally. It places the camera the closest to the actual object of interest, the cervix. We want to identify the length of the cervix. In this image here, you can see that the cervix is curved. A curved cervix in general is normal. You take the two measurements and you add them up, and you have a normal cervical length in this particular image. But if you've undergone training, you're going to know that you need to take time. Cervical length should not be done rapidly. When we have a patient that presents with preterm labor, preterm contractions, she likely is going to have repetitive contraction activity that's coming every few minutes. If you only take 30 seconds to do a cervical length, you're going to miss what is apparent next. Contraction activity often can shorten the cervix, and we're taught and educated when we learn how to properly do vaginal cervical length to identify the shortest, best cervical length over 3 to 5 minutes. And done properly, you'll identify that this indeed is cervical shortening, measuring 5 millimeters. Additionally, in our assessment tools, we've taken a history, we've done a speculum examination, we've done cervical dilation, we can do vaginal ultrasound, we can also do a laboratory test. Fetal fibronectin. First studied by Peaceman in 1997. Fetal fibronectin is a glycoprotein. It's found at the maternal-fetal interface, right between the amnion and the chorion. And when this particular compound is identified in the posterior fornix, it predicts a greater probability of preterm birth. And when it's not found, it definitely predicts a far less chance of delivering preterm. In this initial study, patients had symptoms of preterm labor. Between 24 weeks and 0 days to 34 and 6, they underwent a speculum examination, and if they were under 3 centimeters, fetal fibronectin testing was collected and sent to a laboratory. The fetal fibronectin test was positive if the test is greater than or equal to 50 nanograms. If the test is negative, the predictive ability is very important. The negative predictive value for fetal fibronectin testing tells the clinician, tells me, tells you, that that patient has a 99.5% chance of staying pregnant for 7 days, a 99.2% chance of staying pregnant for 14 days. In medicine, certain things, in your career, in your education, we read a number of texts, and one has stayed with me for a long period of time. The Checklist Manifesto, How to Get Things Right by Atul Gawande is an excellent book that I think all involved in medicine should read and be aware of. And one particular quote has stayed with me and really directed the way I look at how I practice medicine. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists. But we pay little attention on how to make them fit together well. Outside of medicine, there is a culture of safety in all industry. And the approach is to have a standardized path, a standardized approach to establishing a consistent process within an organization. Why do organizations do this? Well, the results are consistent outputs. They look at a process, they define a task, how it's done, who's going to do it, and when the person actually needs to perform the test. This safety culture, adopted outside of the field of medicine, is seen as a cornerstone of continuous improvement. Organizations around the world use the safety culture approach to develop consistency and stability because they know that this will bring many benefits to an organization. It will improve safety. It'll increase efficiency. It'll improve finances and quality. The American College of Obstetricians and Gynecologists wants all of us that care for pregnant patients to adopt a safety culture. This committee opinion, entitled Clinical Guidelines and Standardization of Practice to Improve Outcomes, calls all of us involved in patient care to utilize protocols and checklists. Why? Because it reduces patient harm. ACOG recognizes that when we go about developing protocols and standards, there may be issues. And the issues surround the haphazard approach that we take in general in medicine. Unlike outside of medicine, where things are often much more consistent, a safety culture is adopted, in medicine today, we tend to have a haphazard approach. Why do we have a haphazard approach? Providers have autonomy. I think I'm smarter than Dr. A, and Dr. B thinks he or she's smarter than Dr. A. There's also really little oversight and enforcement in medicine. We come from different areas of training and we have different experience, young and old. Sometimes we have different levels of concern. Sometimes we're running to see the patient. Sometimes we are walking slowly. And unfortunately, there's often conflicting research which leads to a lack of a standard of care. How can we together make an impact today? Can we standardize our processes in medicine? Can we bring some benefits to our organizations, our hospitals, our facilities, our patients? Can we improve safety, efficiency, finances, and quality care for the patient? I believe we can, but it's ever important to implement protocols in the way we care for patients and trust and follow those particular protocols. When you see a patient in obstetric triage, there's a number of different components that we reviewed just previously that are involved in the actual patient's risk of delivering preterm. We can assess her contraction frequency. We can check her cervix. We can identify a transvaginal ultrasound. We can complete a fibronectin, fetal fibronectin test. When we combine things together, we tend to have the best outcome. And when we follow protocols strictly, our outcomes are going to be better. This is an example preterm labor protocol for patients that present with symptoms of preterm labor between 24 weeks and 0 days to 34 weeks and 6 days. The patient presents with symptoms. She's seen in an obstetric triage unit. We conduct a speculum examination, collect and send a fetal fibronectin test result. We then do a cervical examination. If she's 0, 1, or 2 centimeters, this is the perfect window where fibronectin is beneficial. If the test result is negative, we know that patient has a 99% chance of remaining pregnant for 7 to 14 days. That patient can be safely discharged home without administration of antenatal corticosteroids, avoiding unnecessary, inadvertent exposure to a medication that has some controversy surrounding it today. If the testing for fetal fibronectin is positive and the patient's risk is now higher than when she walked in the door because of that particular positive test result, we need to utilize transvaginal cervical length to understand, is the cervical length short or long? And if it is short, that patient is at the greatest risk of spontaneous preterm birth. That is the individual that's going to benefit from antenatal corticosteroids and hospitalization, as I've shown you in a number of studies today. This study by Gomez demonstrates that preterm birth within 7 days is best predicted with utilization of fetal fibronectin testing and transvaginal cervical length. If they're both negative, the probability of delivery within 7 days is exceedingly low, around 2% if the cervical length is over 3 centimeters, and around 3% if the cervical length is over 1.5 centimeters. If both tests are abnormal, your chances of preterm birth are exceedingly high within 7 days, in the realm of 45% if the cervical length is under 3 centimeters, and 75% if the cervical length is under 1.5 centimeters. This is not an understudied area of interest. When you do a literature search looking up the keywords fetal fibronectin, there are over 2,900 articles about this topic. If you add fetal fibronectin and preterm labor, there's over 600 articles studying this particular topic. When we utilize laboratory testing such as fetal fibronectin, there are innumerable studies that identify there are less maternal admissions, shorter lengths of stay for that particular patient. We also know that we can save money if we trust laboratory test results. This study by Iyer demonstrated that when they utilized fetal fibronectin testing in the evaluation of preterm labor, it actually decreased maternal admissions 4% versus 2%, a cost savings of nearly $1 million simply by trusting a laboratory test result and acting on that particular result. We know from this study by Ness, they wanted to evaluate how well do these protocols function in outcomes for patients that have symptoms of preterm labor. And we learned some really interesting facts from this particular study. In this randomized controlled trial, patients presented from 24 weeks and 0 days to 33 weeks and 6 days. They were contracting actively, preterm contractions. They had symptoms of cramping and pressure, and they were under 3 centimeters dilated. And what was important about this particular study is that all the patients were studied using a standardized protocol, which was definitely followed by those involved in the study. There were 100 women randomized to those that followed the protocol and those that did standard management. Their initial outcome was just to see if they could become more efficient. Could they triage patients more quickly, more effectively, more efficiently by using a protocol involving all those attributes and assessment tools that I just covered? You can see that the time was less, about 25 minutes faster, but not statistically significant. But interestingly, in this study by Ness, the rate of preterm birth was actually lower in patients where we knew the results of her cervical length and fetal fibronectin testing, identifying the highest risk patient for preterm birth and potentially treating that patient, reducing her chances of preterm birth. As you can see here in this study, the rate of preterm birth under 37 weeks was 36% versus 13%. This was an unexpected result. When following a strict protocol, the primary outcome was to try to reduce time, but actually what the researchers identified was they reduced the rate of spontaneous preterm birth. This is the only randomized controlled trial using a standardized protocol. And the reduction in spontaneous preterm birth in the group where we knew and followed lab and imaging results was unexpected and occurred despite any significant difference. And ultimately, like many studies, the authors concluded that we needed further evaluation in this topic. This topic has been further evaluated. This is a study that was presented at the ACOG meeting in 2019 by Girardi. large hospital organization in the northeastern United States, looking at 34 hospitals implementing a preterm labor protocol, utilizing those same components that I just went through. They looked at 557 patients that had basically no evaluation by protocol versus 1,200 that were evaluated by protocol, and they looked at a number of clinical outcomes. Were things better for those patients? Were exams more complete? Was lab use better? What was the medication use? And then what were the maternal and infant outcomes? In this study, you can see that simply the physical examination rate improved. The actual examination rate of the cervix improved both for an initial and a follow-up cervical examination. And you can see that laboratory testing increased. Fetal fibronectin testing had previously not been used as commonly and increased, and vaginal cervical length stayed about the same. What is incredibly important about this particular study, a really large real-world study about the power of standardization and protocol use in a large healthcare institution. Trinity identified a lower rate of inadvertent steroid exposure from 20% to 16%, and fewer tocolytics being utilized as well, both statistically significant. They also showed lower rates of maternal admission, reducing unnecessary admission to the hospital for patients. And just similarly to NES, when following a protocol, the rates of spontaneous preterm birth were also reduced. This is the largest prospective study in the United States demonstrating the utility of a preterm labor protocol. It demonstrates a significant reduction in spontaneous preterm birth when hospital facilities and clinicians use a protocol. These findings were unexpected, similar to that of NES years ago, and ultimately we still desire further study on this topic. We know that not all patients are evaluated in an equitable fashion. Not everybody gets all of this comprehensive evaluation. We know this from an article written by Dr. Sean Blackwell, former president of the Society of Maternal Fetal Medicine. In this 5-state national insurance database evaluation, Dr. Blackwell identified 23,000 patients that were evaluated with symptoms of preterm labor. 25% of them are admitted. They're in active preterm labor. They're 5 centimeters, 7 centimeters dilated. But we discharged 3/4 of those patients home. You and I, physicians, trainees, nurses, clinical staff in triage on labor and delivery, after our evaluation, whatever that is, we discharge 3/4 of them. The great majority of them go on to deliver much later. But interestingly, 20% return and deliver within 72 hours. In this real-world snapshot, what was done to those patients? You can see in the graph here, 80% of those women that delivered within 72 hours of a prior preterm labor evaluation had no fetal fibronectin test done. They had no transvaginal cervical length done. We just covered a variety of benefits. How do you evaluate a patient properly? And you can see in this particular study, we're not doing that in the United States. Critical opportunity missed. Were this your sister, your partner, your daughter? How do you want her evaluated? What are the components? How comprehensive? What all do you want involved so that she can get the best care? The Society for Maternal Fetal Medicine recognizes that we have issues surrounding the evaluation of preterm labor. One of the most important medications that we utilize in that evaluation is the administration of antenatal corticosteroids. And they recognize that it needs to be given within 7 days before birth. They go on in this document to understand that and describe that only 20 to 40% of preterm infants actually receive this life-saving important medication. They report low rates of optimal timing of steroids, but additionally, they recognize that there may be actual risks associated with our provision and administration of antenatal corticosteroids, which we often give very liberally. If we give steroids and they're not properly timed, there's science and studies to demonstrate that there is higher NICU admission rate, smaller for gestational age infant births, and risk of childhood, mental, neurocognitive, and behavioral disorders. This is just a snapshot, a quick literature search. Were you to type in antenatal corticosteroids and adverse perinatal outcomes, you can see a number of articles illustrating potential harm to a newborn if exposed in utero to preterm steroids. Neurodevelopmental disorders among term infants exposed to steroids. Associations between maternal antenatal corticosteroid treatment and mental and behavioral disorders. A number of studies that also support why we need to follow strict protocols, not only to identify the highest risk individuals for preterm birth, but also to identify those that have incredibly low risk of actually delivering preterm so that we don't inadvertently expose them to a potential medication that may cause long-term effects. How are we doing? How do you think you're doing in your institution? This is a study from the Netherlands. They were looking at how to improve their evaluation of preterm labor. Prior to the study, they had utilized only transvaginal cervical link, but they were not satisfied with the evaluation, and they added fetal fibronectin testing to all patients undergoing preterm labor evaluations in the Netherlands. This study shows that if you have a short cervix, you have a 1% chance of delivering preterm. But interestingly, clinicians, you and I, we give 20% of those patients steroids. If they have a short cervix but a negative fetal fibronectin, which we know is low risk, only 3% of those patients go on to deliver in 7 days. But over 60% of those patients receive steroids, a medication that might actually cause long-term adverse effects for a child. This is a group that we should not be treating. The SMFM special statement is asking clinicians, us, to do better. There are prediction tools that we can use today, and SMFM acknowledges this. Even without new research, we can improve performance. They're asking us as physicians, nurses, learners, trainees to thoughtfully evaluate the risk of preterm birth within 7 days prior to giving antenatal corticosteroids. There are two particular groups they want us to be very cautious of and avoid administration of steroids. Those two groups are the patient that has an asymptomatic short cervix. Additionally, if a patient presents with preterm labor symptoms and you have collected and received a negative fetal fibronectin test result, we should avoid administration of steroids in those patients because their risk of preterm birth is low. Peaceman, in his initial study in 1997, said the greatest value for the fetal fibronectin test in preterm patients with preterm labor symptoms was its high negative predictive value for impending preterm delivery. He recognized that we could do less intervention, that actually less may be more appropriate for a negative fetal fibronectin result. How can we improve today? We need to be thoughtful in our evaluation and management. We've covered a number of assessment tools in the basic evaluation of patients with symptoms of preterm labor, and we need to use those tools, but we need to use them in a standardized protocol as we're called for by our professional societies. And then we need to adopt our behavior to those test results. Follow the standardization, trust the test results, and you will be pointed on the proper path of care for that patient. We talked about a lot of things. The problem of preterm birth, its evaluation, statistics on outcomes of neonates, potential harms, our abilities to predict who's going to deliver preterm and who's not. And we need to do a better job. We need to standardize, implement protocols, because all of the precursors is only part of the story. The less appreciated burden of preterm birth is borne by the families caring for those preterm babies. We need to do everything in our power before we get to this point. Proper equitable, compassionate, excellent evaluation using a standardized protocol. I really appreciate the opportunity to talk to you today, and I look forward to next time. Thank you for listening.